Yeah, recording started. You can present the case. Hand out to Dr. Purian.
Good evening, everyone. My respected teachers and friends. My patient, Mrs. XYZ, a 35-year-old lady, right-handed, housewife by occupation, resident of Gurgaon, informant, patient herself, and
yes, sorry to interrupt. Dr. Rupam, can you give introduction about you? You are from?
Sir, I'm Dr. Rupam. I have completed my DNB residency from Max, New Delhi, and I am preparing for my practical, sir.
Right. Please continue. Thank you.
Yes, sir. My patient, Mrs. XYZ, a 35-year-old lady, right-handed, housewife by occupation, resident of Gurgaon, informant, patient herself, reliable, and she was examined on 12th of December 2019. She was admitted with history of numbness in both her lower and upper limbs since 2 months, weakness in her lower limbs and upper limbs since 2 months. On elaborating the history of present illness, the patient was apparently all right 2 months prior to the admission, after which she felt numbness in her left feet, which was insidious in onset, without decreased sensation of hot and cold water while bathing. The numbness was initially on the sole of her feet, and it has progressed up to the knee over a period of 2 months. She described that she developed similar pattern of numbness on her right feet after a few days of onset in her left foot. She has also it has also progressed up to her right knee joint. There is history of imbalance on walking with increase which increase with eye closure on or darkness or an unsteadiness while washing her face with water. She also gives history of numbness in her both hands, which has also developed insidiously and simultaneously since last 2 months. It has progressed up to both wrists. No history of any pain or painless scars unnoticed, wound, burns on her feet or hands, decrease or increased sweating disturbances, stiffness of limbs, slowness of activities, or clumsiness or tremulousness in hands. The weakness of her lower limbs since 2 months was gradual on onset, and it was gradually progressive. She gives history of slipping of chappals from her both feet without knowledge, which was but there was no difficulty in inserting foot in the chappals. She requires support of objects for up squatting and took support of railing while climbing upstairs since last 2 months. She also started difficulties in doing her fine activities with her both hands, like holding small objects, mixing food bolas since last 2 months, which developed gradually. Also, there was difficulties in lifting heavy objects and performing overhead activities with her both hands since last 2 months. She has also noticed mild thinning of her left palmar prominences since last 1.5 months, although she denies any history of neck pain, radiating pain, bladder and bowel disturbances, twitching of muscles, or thinning of arms, shoulders, thinning of mouth, shoulder muscle, or any speech disturbance or deformities in hands and feet. No history of any difficulties in getting up from lying down, or any difficulties in turning right and left, or any difficulties in lifting neck above pillow. No history of any visual disturbances or night vision impairment, double vision. She can feel sensation of touch and pain on both sides of the face equally. No history of any chewing difficulties. No difficulties in using a straw while drinking. She opens her does not open her eyes on sleeping. No swallowing difficulties. No deafness, nasal regurgitation of food, and No change in her voice.
I'll just
No.
disturb you once there. We say that maybe better to say that the family, none of the family members have seen her eyes being open while sleeping. The sentence construction. No?
Okay, okay, sir. Okay, sir.
Just what
Sorry.
you were hinting at, that patient was not able to open the eyes during sleeping. So that's what I understood what you meant. What were
Yes,
you
sir.
getting at?
Yes, sir.
What was that specific negative history for?
Sir, keeping her eyes open during sleeping is a difficulties in eye closure, and it is seen in condition like FSSD or this.
No, don't go to the etiology. Patient's
Yes, sir.
eyes are open during sleep. What does that indicate?
Sir, orbicularis orbicularis ocular weakness, sir.
Yes, so it indicates a certain weakness any condition, whether it can be neuromuscular junction disorder, myopathy. Okay. So just that sentence construction was wrong. That's why I invited you.
Yes, sir. Pardon, sir. There's some kind of difficulties, disturbances in network, sir.
No, that sentence construction that you used was not appropriate. So the family members have not noticed that the patient's eyes are open during sleep. That is the way you should put it across.
Okay, sir.
Or in the history level, you can even say that since it is a negative history, no history suggestive of any, say, facial weakness. That also is fine. Yeah?
Yes,
so, So it indicates just a subtle, it's an earliest indicator of a subtle facial weakness. It does not point
yes,
towards the etiology like FSSD. Okay, continue.
Okay, sir. Okay, sir. Okay, sir. No history of any deafness, nasal regurgitation, change in voice, breathing difficulties, or seizure. No history of any abnormal sweating, postprandial fullness, diarrhea, posterior giddiness, or impotence. No history of any photosensitivity, rash over face. No history of exposure to a case of Hansen disease. No history of any
How did
toxin
you ask
exposure.
for history of impotence?
Sir, in case of male early.
What is the sex of the patient here?
Pardon, sir?
Patient is a female, right?
Yes, sir.
So see, be careful when you are saying. See, this is the pattern that you have been following. But so you are that specific sentence. Why did you use that?
Sir,
I know
see,
abnormal sweating, postprandial fullness, diarrhea, postural headedness, impotence.
Sir, to see to rule out any autonomic information.
Autonomic dysfunction. So don't use impotence. That the terminology.
Yes, sir. Sorry, sir.
Okay.
So no history of any photosensitivity, rash over face. No history of exposure to a case of Hansen disease. No history of any exposure to toxins or chemotherapy drug use. No history suggestive of any malignancy. No history of any jaundice. No history of recurrent diarrhea, abdominal pain. Past history, patient has a history of multiple small and large joint pain since last 2 years, and she was taking Ayurvedic medication for it. No history of
So
any
you
morning.
mentioned there were no history of toxin use. See, then now you are saying that Ayurvedic medication she was on. Maybe you are being politically correct by saying that Ayurvedic medications don't contain any toxins. But many a time, patients who take alternative medications, we get heavy metal toxicities. It is quite a common cause for a neuropathy. You must have encountered it, correct?
Yes, sir. Sorry.
So maybe you are using the saying in the negative history. You just now said that there is no history of toxin exposure, and 2 sentences later, when you say that the patient was on Ayurvedic treatment for a polyarthritis, maybe it does not go in tandem.
Yes, sir. Yes, sir.
Okay, continue.
Yes. No history of any morning stiffness. Non-diabetics. She is not a non-diabetic, non-hypertensive. No history of any addiction to alcohol or any drugs. She consumes a mixed diet. She has history of hypothyroidism since last 4 years and on treatment for the same 100 micrograms daily. No history of any abdominal tuberculosis or the gastric bypass surgery or history suggestive of pancreatitis in the past. Family history: she's married in 12 years with one son and daughter. All are and her husband, and all are enjoying good health. No family history of similar illness or any food deformity or family history of using walking device. Summary.
Before summarizing, I think we will analyze the history. So you have not mentioned the dietary history, right? Did you say?
Dietary, she consumes a mixed diet, sir.
She consumes a mixed diet. Okay.
Yes, sir.
Okay. So, she is her occupation? Housewife.
She's a housewife, sir.
Housewife, she is. Okay.
Yes, sir.
So you have mentioned about the personal history, occupational history, and dietary history. That's fine. So now
Yes, sir.
you analyze each of the symptoms that the patient is having.
So first of all, patient presented with numbness. It was from the for last 2 months. Initially, it was on the left side, and after 2 months, it was on the right side. So it was only numbness without any hot and cold water, loss of any sensation of hot and cold water. So, so numbness means mainly small fiber involvement, sir. But
so, numbness is for small fiber.
Yes, sir. Numbness.
How do you classify sensory symptoms?
Sensory symptoms are positive symptoms and negative symptoms, sir.
Okay.
Positive symptoms are pain, paresthesia, hyperesthesia, pain and needle sensation. Then negative histories are negative symptoms like numbness, weakness, hyposthesia.
Okay.
Then and positive history also the hyperalgesia.
Okay. So out of these symptoms, so the patients with a neuropathy can present with negative sensory symptoms or positive sensory symptoms. So
yes, sir.
Now, can you tell me the receptors which are responsible for each of these particular symptoms?
So pain scores are pain receptors are free nerve ending.
Okay. So the nociceptive receptors are the free nerve endings.
Free nerve endings, sir. Then, sir, task receptors are
and also the Merkel's endings.
Merkel's, sir.
Okay. So the non-encapsulated receptors are free nerve endings and Merkel's endings. Both of these are responsible for pain sensation and temperature sensation. Then, what are the second group of receptors?
Sir, Golgi tendons?
No. See, what I meant is the positive and negative sensory symptoms. See, that is what we were discussing, right? Golgi tendon organ, does it subserve a positive sensory symptom, or which one does it take care of? Positive sensory symptom or negative sensory symptom?
Sir, positive, sir.
So the Golgi tendon organ takes care of positive sensory symptom.
Yes, sir.
Okay. So see, always think before you answer. Golgi tendon organ is for proprioception. It's not for positive and negative sensory symptom. So can you tell me which all receptors are involved in assessment, or how does the patient subserve proprioception? Which are the receptors involved in proprioception?
So, pardon, sir, I have forgotten this.
So proprioception is by the joint receptor, it is by Golgi tendon organ, and it is by muscle spindle.
Yes, sir. Yes.
Proprioception has a component for the fine touch. Usually we don't say these three things: muscle spindle, Golgi tendon organ, and joint receptors for positive or negative sensory symptoms. Okay.
Yes, sir.
So always just wait for a moment and then answer the thing, because once you bring in Golgi tendon organ, the discussion will move away from that. So here you have positive, the patient is mainly having a negative sensory symptom, numbness.
Yes, sir. Yes, sir.
This started asymmetrically.
Yes, sir.
And then the patient, so we will first analyze the negative the sensory symptom only. So the patient has got a negative sensory symptom which started asymmetrically. So
Yes, sir.
is there a chance that this is, do you think, can this be symmetrical onset?
Sir, yes, sir, it can also be symmetrical onset.
So always no, when it is easier to say that it is, that's a very important thing. Patients with Mononeuritis multiplex, when the symptoms start asymmetrically, it
Yes,
usually has to be a positive sensory symptom. Many a time the patients might observe a negative, if it is a negative sensory symptom, the asymmetrical onset is something that is difficult to see. Say she will touch, she will feel that one area is numb. If it is a positive sensory symptom, it will be readily appreciated. So here it even can be a symmetrical onset also, because why I meant to say that it is only, the patient is only having a negative sensory symptom. So your patient has got a numbness which is involving one lower lip followed by the other. So numbness is a negative sensory symptom. So now we were discussing the receptors, the non-encapsulated receptors which are responsible for subserving pain and temperature, that is free nerve endings and Merkel's endings. Okay.
Yes, sir.
Now the encapsulated nerve endings which are responsible for touch.
That's yes, sir.
Touch. What are the encapsulated nerve endings? Sorry, encapsulated receptors.
Sir, Pixinian corpuscle and Meissner's corpuscle.
Okay, Meissner's corpuscles, Pacinian corpuscles, and Ruffini endings. So these are the ones which are encapsulated. So these are the so these receptors are responsible for subserving positive and negative sensory symptoms. Muscle spindle, Golgi tendon organ, and the joint receptors don't have a role in positive and negative sensory symptom. Okay.
Yes, sir.
Okay. So now your patient has numbness. So now the patient has got a small fiber neuropathy or a large fiber neuropathy.
Yes, sir.
You said the patient has a small fiber neuropathy, no?
Yes, sir.
What do usually small fiber neuropathy patients present with? You would have had a lot of alcoholic patients, diabetic patients who come to you and they are never happy. They keep on coming to your OPD. Those are the patients.
Yes, so pain, paresthesia, burning.
Yes. So patients with a small fiber neuropathy have got severe pain, hyperesthesia, hyperalgesia, hyperpathia. They have their extremity, they might have some swelling over there, the distal extremities, redness of the extremities. So that is the feature of small fiber neuropathy. So here your patient is having numbness.
Yes, sir.
So there, and also now when we come to the next part of the history, the second symptom is a weakness. The small fiber neuropathy cause weakness?
No, sir.
No. So your symptoms are both for the same period. No, 2 months history of sensory symptoms in the form of numbness, and along has imbalance and weakness. So there, don't bring in a small fiber neuropathy. You can bring small plus large fiber neuropathy if you want, but small fiber neuropathy alone, saying that is not correct. Is it clear?
Yes, sir. Yes, sir.
Okay, so the important thing you should know is that the small fiber neuropathies cause mainly positive sensory symptoms. Small fiber neuropathies have got hyperpathia, hyperalgesia, redness of extremities, sometimes even swelling. Small fiber neuropathy does not cause weakness, does not cause imbalance.
Yes, sir. Sir, yes, sir.
Now, which nerve fibers are affected?
Sir, along with numbness, there is she also.
No,
she also
if it is numbness, so okay, then we will discuss that later. So along with the numbness, so initially the patient had numbness over the left foot, and then it progressed up to the knee, and a few days after that she had numbness over of the right foot also. correct?
Yes, yes, sir.
So the onset was asymmetrical. Was the progression symmetrical?
Sir, initially it was asymmetrical, but later it involved to both sides of the leg, and it progressed together. So.
Okay, so that is why I mentioned that the patients who have a negative sensory symptom, the onset might be found to be asymmetrical, but it still might not be a mononeuritis multiplex. It might be a simple peripheral neuropathy or it's a peripheral neuropathy with only negative sensory symptom. Because of that, the patient noticed in one lower limb. Is it clear?
Yes, sir. Yes, sir.
Okay. So now you are saying that the patient had an asymmetrical onset, but later the symptoms started progressing symmetrically. What is a confluent mononeuritis multiplex?
Pardon, sir?
What is confluent mononeuritis multiplex?
Sir, confluent mononeuritis multiplex is located in a particular part of the body along with the distribution of the nerves, sir. Particular area it is located.
We'll go a little more backward. So what is mononeuritis multiplex?
Sir, involvement of more than two nerves in a non-compressible, non-entrapment science.
So involve damage to at least two named peripheral nerves at non-entrapment sites, usually at non-entrapment sites. So
yes.
What is the mechanism of mononeuritis multiplex? How does it happen?
Sir, there is inflammation around the vasa nervosum, leading to inflammation of the perivascular tissues involving the nerves and leading to any conduction disturbances.
Okay. So mononeuritis multiplex is a damage to two named peripheral nerves at non-entrapment sites, and
yes,
their
sir.
vasa nervosum is affected, and the patient has got ischemia. That is why the nerve injury happens. So
yes, sir.
Here your patient can have the possibilities based on numbness alone. When you are considering, you have three possibilities. Either can be a mononeuritis multiplex, or it can be a peripheral neuropathy, which was noticed asymmetrically because it was only negative sensory symptom, or it can be it started as a mononeuritis multiplex, and the patient now has got a confluent mononeuritis multiplex. That is when mononeuritis multiplex progresses and affects a lot of nerves, and as a result, the pattern of involvement becomes symmetrical. Is it clear?
Yes, sir.
So that is a confluent mononeuritis multiplex. Okay. Then continue.
Yes, sir. See, also give history of imbalance while walking, which increase on eye closure on darkness, and unsteadiness while washing washing her face with water. She also gives history of numbness of her both hands, which
So I
has
think
also
this is something that you should keep in mind. When you are saying about numbness, you should not bring in imbalance and weakness. You should analyze one symptom. How was the onset of that symptom? How it progressed? So onset, duration, progression, what aggravates it, what worsens it, what is the current status of the thing. So when you are analyzing numbness, you have to say numbness of the upper limb also. Before saying finishing the history of numbness, you should not move on to imbalance.
okay, sir.
Okay. So the patient had, you can say immediately after the numbness history, you can say imbalance. So we will keep that sentence there. Now you tell about the numbness of the hands.
She also gives history of numbness in both hands, which has also developed insidiously and simultaneously since last 2 months. It progressed up to both wrists.
Okay. So the patient has got everything started 2 months back. So the lower
yes.
limb symptom and the upper limb symptom. So in
yes,
upper
sir.
limb, it has started symmetrically and simultaneously. Okay.
Yes, sir. Yes.
So since the patient has lower limb and upper limb involvement, isn't
Yes.
it a length dependent neuropathy?
Sir, so maybe, sir, but according to the patient,
No.
it is.
This patient, does she have a length dependent neuropathy or not?
Sir, usually length dependent neuropathy, sir, starts mainly in the legs, then on reaching up to around a knee, then it starts in the hands, sir.
Okay, so it is not a pattern of a length dependent neuropathy. Length dependent neuropathies usually start, like you said, in the feet, ascend up, and once it reaches up to the knee, then the hands
Yes.
are involved. Okay.
Yes, sir.
Simultaneous involvement is not a feature of a length dependent neuropathy. Okay.
Yes, sir.
Okay. Then continue. So she has numbness, which has gone up to the wrist. She has numbness.
Yes, sir.
So in the upper limb also, she does not have any positive sensory symptoms.
No, sir.
Okay. Now you analyze the imbalance.
Sir, she gives history of imbalance on walking, which increase on eye closure and walking in darkness, and she also feels uneasiness while washing her face in water.
What does that indicate?
Sir, mainly, sir, sensory ataxia, sir.
Okay.
Mainly large fiber involvement, sir.
Okay. So large fiber neuropathy. So that is also for 2 months. So here, the patient, there is nothing pointing towards an exclusive small fiber neuropathy because everything started simultaneously. It is mainly numbness, and the patient also has a sensory ataxia.
Yes, sir.
Okay. Continue.
Yes, sir. History of the numbness in hands progress up to both her wrist. There is no history of any painless cuts, unnoticed wounds, burns in her feet or hands, or decrease or increase sweating disturbances, or stiffness in limbs, slowness in activities, or clumsiness or tremulousness in hands. Sir, though she has numbness, but there is no history of any history of unnoticed injury or any tremors or any slowness or stiffness in hands and legs.
Okay. So this clumsiness or tremulousness in hands, what does it? Why did you specifically mention that?
Clumsiness word is used mainly to rule out to depict cerebellar involvement.
Okay.
And tremulousness, there is no history of any tremors.
Okay. So tremor, can a neuropathy patient have tremor?
Yes, sir. She can have, sir.
What does the presence of tremor point towards regarding the pathology?
Sir, mainly, sir, this
The type of neuropathy.
sir, there may be associated tremorogenic circles, sir.
I didn't understand.
Sir, I'm not sure, sir. This point, sir.
No, what I meant is about your patient has got a neuropathy, and if the patient has neuropathy, she can have tremors. What
Yes, sir.
type of neuropathy is prone to develop tremor?
Sir, anterior horn cell, sir.
Anterior horn cell. So do you mean to say that anterior horn cell involvement will cause tremor or something else?
Sir, sorry, sir. Fasciculation, sir.
Fasciculation, say polymini myoclonus, those will be. So usually demyelinating neuropathies, no? Axonal rather than axonal neuropathies. Demyelinating neuropathies will be associated more with tremors. Okay.
Yes, sir.
Okay. And no, continue.
Then, sir, she also complains of weakness in her lower limb since last 2 months, which was gradual in onset and progressive. She gives history of slippage of supples from both feet without knowledge, but there is no difficulties in inserting her foot in the supples. She requests support of objects for up squatting and took support of railing while climbing upstairs since last 2 months. She also started difficulties in doing fine activities with her bones as like
The connection is poor.
pardon, sir?
No, it got kind of disconnected in between. Okay, so the weakness you were telling, please.
Yes, sir. So weakness of her, she also complains of weakness of her lower limbs since last 2 months, which was insidious in onset and gradually progressive. She gives history of slippage of supples from her both feet without knowledge, but there was no difficulties in inserting her foot in supples.
So what does that mean?
Sir, slippage of supples without knowledge means again, sir, there is distal sensory involvement.
Sensory involvement, but the patient is able to insert well means?
Muscles power, distal muscle powers are intact, sir.
Okay, at least at that time, the patient's distal muscle power seems to be intact. Then?
Yes, sir. Yes, sir. She also requires support of object for squatting and took support of railing while climbing upstairs since last 2 months. Sorry, sir. She is also having difficulties in mixing food bolus since last 2 months, which developed gradually. And she also having difficulties in lifting heavy objects and performing overhead activities with her both hands since last 2 months. Sir, mainly she is giving history of mainly distal sensory involvement of legs and which progressed up to this proximal weakness in the form of difficulties in squatting and climbing upstairs. Sir, she's also having difficulties in mixing food with hands, means mainly distal muscle involvement and difficulties in lifting her.
Okay. So if she
hands.
has got a symmetrical lower limb proximal muscle weakness. And
yes, sir. Distal to proximal.
No, you said no distal weakness, right?
Sir,
lower limb, is there a distal weakness?
Sir,
there is no buckling of the lower limb. The patient has difficulty only in climbing stairs. You did not mention any difficulty in climbing down. The patient is able to put on the chapel easily and smoothly and fast and is able to grip onto it. Sometimes the chapel
yes, sir.
is not aware. But so your history does not show that the patient is having a distal lower limb weakness. Does it?
Yes, sir.
Specifically mentioned that there is no distal lower limb weakness.
Yes, sir.
No, is there a weakness?
Sir, patient had weakness, sir, but mainly she.
So historically, it is not there.
Historically, yes, sir.
So historically, you have got a lower limb symmetrical proximal weakness and upper limb proximal plus distal weakness. Is it correct?
Yes, sir. Yes, sir.
Okay.
She is also giving history of mild. She is also noticing of mild thinning of her hands in her.
This slipping of chapel he has mentioned, I think.
But he said slipping of chapel. He actually specifically said that it is due to the lack of sensation, and the patient is not aware. Rather than so he initially. So I just wanting him to say that there is a distal weakness.
Yeah. Okay. Okay, go ahead.
Yes, sir. She is also noticing mild thinning of her.
So I just want to mention this again. See, you have had the benefit of seeing the patient. So if you feel there is a definite distal weakness, you should not mention that historically there is no lower limb distal weakness.
Pardon, sir?
See, you have the benefit of having examined the patient already at this particular point. So if the patient has distal weakness, you do not say in the history that there is no history of distal lower limb weakness. You can say that the slipping of chapel is both due to a both sensory plus motor component.
Yes, sir. Yes. Sir.
Okay.
Sorry, sir.
Okay, continue.
She has also noticed mild thinning of her both hands on the palmar prominences since last 1.5 months. Although she denies any history of neck pain, radiating pain, bladder and bowel involvement, twitching of muscles, or thinning of arms, shoulders, or there's no any speech disturbance, any deformities of hands and feet.
Okay. Is there any sensory abnormality over the trunk?
No, sir.
If can the patient, such a patient, with a neuropathy, have sensory abnormality over the trunk?
Yes, sir. She can have, sir.
Okay. So in such a patient, if the sensory abnormality is present over the trunk also, then how will you differentiate whether it is a sensory level due to a spinal cord pathology? Your patient is having predominantly a proprioceptive component, no? So I will say that it is due to the posterior column being affected.
Sir, if sir, usually it is in neuropathy, sir, it is symmetrical, sir, bilateral.
No, not asking about that. I am asking if this particular patient has in addition sensory abnormality over the trunk.
Yes, sir.
Can it happen with neuropathy? If so, how will you differentiate it from a spinal cord involvement?
Sir, on spinal cord involvement, it is usually there. It is in a defined, sir, this segmental territory, but usually in case of neuropathy, it is patchy. Maybe it is patchy, sir.
Okay, I will give you one more clue. If it is a axonal neuropathy, which is causing a sensory symptom on the trunk, how will you differentiate it from a cord pathology?
Sir, on axonal pathology, there will be,
neuropathy.
Sir, there will be atrophy on the involved side, sir.
Okay. No, what I meant is it will again be length dependent. So the spinal cord, if a patient has got the neuropathy has a sensory symptoms on the trunk, usually will be more affected, or it starts in the anterior chest rather than posteriorly. The sensory level will be uniform throughout, whereas in a patient with a neuropathy, the patient will have a wedge type sensory involvement, mainly affecting the anterior chest.
Yes, sir. Yes.
There was actually that there is a particular name. There was some French name for that phenomenon. If anybody can answer, it's a favorite question of my examiner, Dr. Thomas Matthew from St. George. So yes, I am not sure. I don't remember that, but you can check that one. So the sensory involvement over the anterior trunk. So the nerve fibers originate from the back and they travel. So in an axonal neuropathy, length-dependent involvement, the sensory symptoms the patient can have over the anterior chest first, followed by a progression. So here also it will be a length-dependent neuropathy.
Yes, sir.
Okay, continue.
There's no difficulties in getting up from lying down position or turning right and left, or any difficulties in lifting her neck above pillow. No history of any visual disturbance, disturbances or night vision impairment, double vision. Can feel the sensation of touch and pain on both sides of the face equally. No chewing difficulties or difficulties in using a straw. No history of any opening of eyes during sleep. No history of difficulties in swallowing. No history of any deafness, nasal regurgitation, change in tone of the voice. No history of any breathing difficulty or seizure. No history of any abnormal sweating. No history of any postprandial fullness, diarrhea, posterior giddiness. No history of any photosensitivity, rash over face. No history of any.
So, diarrhea and why did you specifically ask? Diarrhea and abdominal fullness?
Sir, mainly in autonomic involvement, there is postprandial diarrhea and nocturnal diarrhea, sir.
Okay. In addition to
then
that, patients with
Whipple disease and
Whipple's
other disorders like Crohn's disease or ulcerative colitis may also have some neuropathy.
So neuropathy, along with if the female patient has got photosensitivity and abdominal distension, which conditions you will think of? Maybe some cognitive involvement also.
Sir, porphyria.
Okay, so porphyria, Whipple's, these are also the patients can some toxic neuropathy, toxin-related neuropathies also. Abdominal pain, distension, diarrhea, all of these can manifest. Which are the toxins which can present in such ways?
Sir, diarrhea mainly. Sir, arsenic poisoning also, acute arsenic poisoning may cause diarrhea, sir.
Okay. Continue.
There is no history of any photosensitivity rash over face. No history of exposure to a case of Hansen's disease. No history of exposure to any chemotherapeutic drugs. No history suggestive.
Maybe the chemotherapeutic drugs.
No history suggestive of any malignancy. No
Is
history
there
of
any
any.
weight loss?
No history of any significant weight loss, sir.
No significant weight. Okay. What is significant weight loss?
10 kgs in 1 month, sir.
10 kg in
1 month, sir.
Okay, 10 kg. I thought I don't think it is 1 month.
So maybe,
Okay.
sir, maybe, sir, I forgot that.
I think it is 10% of the patient's weight. Say anybody rather than 10 kg, and it is not 1 month.
Is 1 year.
1 year. Okay, in 1 year. So the patient can have, even a child to an elderly person can have a significant weight loss. So you can say the percentage of the body weight.
Yes, sir. 10% in 1 year. Okay. No history of any no history of any jaundice. No history of any recurrent diarrhea, abdominal pain, sir.
Okay.
Past history: patient has history of multiple small and large joint pain since last 2 years. Was taking Ayurvedic medication for it. No history of any morning stiffness. No history of any diabetes, hypertension. No history of any addiction to alcohol or drugs. She consumes a mixed diet, sir.
Any deformities, joint deformities, anything is there?
Sir, tenderness was there, sir, on examination.
No, historically there is only large plus small joint involvement.
Yes, sir.
Is it a symmetrical involvement?
It was symmetrical, sir.
Okay. So she has got a symmetrical polyarthritis with a large plus small joint involvement.
Yes, sir.
Is it a degenerative arthritis?
Sir,
how do you differentiate historically between degenerative and inflammatory arthritis?
Sir, inflammatory arthritis are usually in the age will be earlier in onset.
So younger age. Then?
Yes, sir. Then, sir, there is associated pain, inflammation, tenderness of the joints.
Okay.
And then
pain, inflammation, pain and tenderness can be there with the degenerative arthritis also.
Yes, sir. But inflammation and this inflammation, it is more in the this inflammatory arthritis.
So many patients with osteoarthritis you have seen with the redness and the pain and the swelling involving the knee joint, right?
Yes, sir.
So do you think this is a degenerative arthritis or an inflammatory arthritis? If so, why?
So it is mainly younger in onset, and it was symmetrical, sir, and mainly involving large and small joints, both large and small joints, sir.
So always keep in mind, young age.
Yes, sir.
Is for inflammatory arthritis. Involvement
Yes,
of
sir.
mainly of the weight-bearing joints is for degenerative arthritis. So you have low back, hip, knee joint involvement. That is for it's a degenerative arthritis. Patients
sir.
with a small plus large joint involvement is for an inflammatory arthritis. Morning stiffness is for inflammatory arthritis. Pain occurring at rest and improving with activity is for an inflammatory arthritis. Pain worsening with activity is for a degenerative arthritis. Okay.
Yeah. Yes, sir.
So all these points you have to say. So even though it is a neurology case, when a prominent history of arthritis is there, whether it is a degenerative or inflammatory, all the points you have to say. Is it clear, or you want me to repeat once more?
Yes, sir. Yeah, sir. Yeah. So I want to.
Okay, I'll tell
okay,
once
sir.
more. So involvement of weight-bearing joints is for a degenerative arthritis.
Degeneration. Yes, sir.
Elderly people, it is usually a degenerative arthritis. Younger age is more for inflammatory arthritis.
Yes, sir.
Large plus a small joint involvement is more for inflammatory arthritis. Morning stiffness is a pointer towards inflammatory arthritis. Pain which is more at rest is for inflammatory arthritis. Pain which increases with activity is for degenerative arthritis. See, here you have a neuropathy patient. So you are going to link this patient's neuropathy with this arthritis.
Yes, sir.
I'm sure. So
yes, sir.
in setting, you have to point out that this is an inflammatory arthritis. This is a young lady who has come with an arthritis. So which all conditions you will keep in mind in such a patient?
Sir, mainly, sir, inflammatory arthritis, like rheumatoid arthritis, and then
no morning stiffness. No morning stiffness. You said no deformities.
Yes, sir. But she's taking
Commonly,
medicine.
do you see patients which connective tissue disorder, which group of connective tissue disorders you see with neuropathy and arthritis? Is it rheumatoid arthritis or something else?
Sir, you can get in SLE, sir. Then
Yes.
mixed connective tissue disorder.
So SLE, mixed connective tissue disease, so all of those are associated with mainly with a neuropathy with an inflammatory arthritis. Rheumatoid arthritis, no, without any morning stiffness, no deformities, though it is possible, maybe you can say down in the list rather than first.
Yes, sir.
Okay, so the arthritis, it's a prominent symptom. That also you should take the history carefully.
Yes, sir.
Yes,
she has history of hypothyroidism since last 4 years and was on treatment for the same Tyronom 100 microgram daily. No history of any major illness like abdominal tuberculosis, gastric surgery, or history suggestive of pancreatitis. Family history: she is married since 12 years and she lives with her husband, one son and one daughter. All are enjoying good health. No family history of similar illness or any or history of any food deformity or walking with the help of walking device. Summary: my patient, 35 years old female, with presented with subacute asymmetrical onset, progressive sensory symptoms, numbness and gait imbalance, worsening in the dark, and motor weakness, distal more than proximal in the lower and upper limbs without any autonomic involvement, bladder and bowel, cranial nerves, or any associated family history. Which
so why
chronic
that the patient has got distal more than proximal weakness? You can say distal and proximal weakness. She is having difficulty in climbing. She has to take support of the rail, and that is also quite disabling, right? She's not able to upper limb. Also, proximal weakness also is there. Historically, did you find a disparity? From your presentation, I did not feel a significant disparity that it is a distal more than proximal weakness.
So in hands, along with weakness, she is also giving history
the
of
thinning of the limbs also
thinning of the limbs.
Upper limb, maybe the weakness is distal more than proximal in the upper limb. Okay.
Yes, sir. But lower limb as such, from the history, sir, there was no such disparity, sir.
Okay. So, where do you want to localize?
This regarding this asymmetry, how much gap was there? How many days?
Sir, 2 months, sir.
Okay.
No, there are
Okay.
no, the history is only for 2 months. No, it was what sir asked is that the left lower limb followed by the right lower limb, the symptoms were noticed. How much gap was there?
Sir, 2 months, sir.
Not 2 months. No, can you? You said few days, right? In the initial history. Can you look at your initial presenting complaint?
Yes, I wrote few days, sir.
Well, you said few days. Not if it is 2 months, then there is definitely it is a mononeuritis multiplex. Why have we had the discussion earlier is because you said everything is a history of everything. It's numbness is for 2 months. The imbalance is for 2 months. The weakness is for 2 months. The only thing that is asymmetrical here.
Yes, sir. Sir, exact duration, sir, it was, I took it long back, sir. Exact duration, I forgot to write it properly.
Okay. So it may be symmetrical probably.
Maybe, sir.
Dr. Korean? Okay. What is your localization?
Sir, localization mainly in the, sir, peripheral nerves, polyradicular, more involving both small and large fibers. Then, sir, less likely, sir, under down this list, sir, spinal cord and flexus.
Okay. And etiology wise?
Sir, according to history-wise, sir, CIDP and then connective tissue disease, and vasculitis, then metabolic factors like diabetes mellitus, down the list, inflammatory or paraneoplastic, but it is less likely, sir.
But patient had hypothyroidism also.
Yes, sir. Then, yes, sir, metabolic like DM and hypothyroidism.
Okay. What is acute, subacute, chronic in neuropathy? How much is the gap?
Sir, chronics are more than 2 months. Acute less than, sir, 14 days, sir, 2 weeks. Then 2 weeks to 2 months is subacute, sir.
Okay. What are the causes here? It is almost subacute to chronic, I think. So what are
Yes,
the
sir.
causes of subacute neuropathy?
Sir, subacute means early presentation of CIDP, sir. Then metabolic causes, then post-infectious usually less likely, sir. Then
Okay, sorry, I'm sorry, my connection, my phone got disconnected. There's rain here. Sorry.
Yeah, no problem. So he was saying regarding some subacute neuropathies, differential diagnosis.
Okay.
Yeah,
So,
go ahead.
okay.
You start
Sir,
from the localization, Dr. Rupam.
localization, sir, mainly, sir, involving peripheral nerves, both small and large fiber involvement. Then less likely, sir, on the down that list, sir, spinal cord and flexus, sir, second and third.
Spinal cord, how you have kept in the second possibility?
Sir,
Okay, why did you say spinal cord?
sir, usually, sir, it is less likely, but
No, in
is-
here, is there any particular point in the history that you need to, that is pointing towards spinal cord?
sir, only, sir, leg weakness, asymmetrical.
See, if there is unless there is a particular thing pointing to spinal cord, you don't need to bring in spinal cord here, no?
Yes, sir.
Patient has got upper limb. At what level, if the patient has involvement, will the patient have proximal upper limb plus proximal plus distal upper limb weakness and proximal plus distal lower limb weakness in this particular way?
Sir, less likely, sir. Sometimes it may happen in that multi-segment involvement in, sir, like some multiple segment involvement of this spinal cord, sir. But it's really less likely, sir.
Okay. No, because from the history, it looks more like a, it's definitely nerve is your main localization.
Yes, sir.
So the examiner will ask you whether out of all the levels of the neuraxis which can cause a lower motor neuron pattern of involvement, why you don't feel it is spinal cord, why you don't feel it is plexus like that. So here, can a plexus involvement cause this? And if why can't it be plexus?
Sir, plexus is usually asymmetrical, sir. Plexus involvement, and there is associated pain, atrophy. Although there may not be atrophy in the early stage. Usually plexus is asymmetrical, sir.
Okay, so here again bringing in plexus without an asymmetry, without a significant positive sensory symptom, without any twitching of the muscles, in a subacute to chronic neuropathy, bringing in plexus might not stand you in good stead.
Yes, sir.
So you can say when it is a clear-cut case, you can say that history-wise it looks like a likely a subacute neuropathy. Okay, based on duration, how do you classify neuropathies?
Sir, acute, subacute, and chronic, sir. Acute up to less than 14 days, sir. Then 2 weeks to 2 months it is subacute. Then more than 2 months it is chronic, sir.
Okay. Acute is less than 4 weeks. Is what is your reference? Is it 2 weeks? Acute is less than 4 weeks. No. Which is the most common acute polyradicular neuropathy?
Sir, Guillain-Barré syndrome, sir.
So in Guillain-Barré syndrome, you expect the patient to progress for and reach the plateau by what duration?
Sir, 30 days, sir.
28 days. Okay, 4 weeks. So
yes,
an acute neuropathy is for 4 weeks, not 14 days. It's not 2 weeks. Subacute neuropathy is 1 to 2 months. Some books even say that in 1 to 3 months. And chronic more than 2 months, and some books say that it is more than 3 months.
Yes, sir.
Okay, so here you have a patient with a subacute neuropathy. Not so. Continue.
Yes, sir. So likely it's etiology. So my localization, sorry, sir. Likely etiology would be, sir. First DD would be, sir, CIDP, and next connective tissue disorder or causing vasculitis, and metabolic disorder like hypothyroidism or diabetes mellitus.
So these are not different etiologies. So here you see the cause of CIDP can be a connective tissue disorder or a vasculitis. You are talking about the etiology, correct?
Yes, sir.
So you feel the patient has got a polyradicular neuropathy, correct?
Yes, sir.
So the patient has got a polyradicular neuropathy with a small plus large more than small fiber involvement with now currently symmetrical distal plus proximal weakness. So it is likely a polyradicular neuropathy.
Yes, sir.
So with the duration, you feel it is a
CIDP, sir.
it is a CIDP. So it is a, and also it is a progressive pathology, right?
Yes, sir.
Can neuropathies have a relapsing and remitting course?
Yes, sir. CIDP.
Okay. Which are the
CIDP may,
neuropathies which can have a relapsing and remitting course?
sir, CIDP, sir. Then metabolic, then
Metabolic.
yes.
Metabolic neuropathies can be, which metabolic neuropathies can have relapsing remitting course?
Sir, this porphyria and amyloid, sir. One
Okay.
vasculitis.
So porphyria is a CIDP, porphyria. So CIDP per se can have a relapsing remitting course, and porphyria is another one.
Then toxin exposure, sir.
Okay, toxin exposure. So the patient has toxin exposure from time to time. Then again, the patient can have a relapsing remitting course. Is there any inherited neuropathy which can have relapsing remitting course?
Sir, HNPP, sir.
Okay. So now again, so here you have a patient with likely a CIDP, and the patient has got a progressive course with distal plus proximal involvement, both upper limb and lower limb affected, with a significant connective tissue disorder being present. Correct?
Yes, sir. Yes, sir.
Okay. So now something that we discussed earlier. Which are the nerve fibers which are affected here predominantly based on the patient's symptom?
Sir, mainly small and large fibers, sir.
Is it large more than small, small more than large, or small and large?
Both small and large, sir.
Okay. So it's mainly large, no? You don't have any positive sensory symptoms. There are no autonomic symptoms. Small fiber neuropathy patients, like we discussed earlier, will have positive sensory symptoms and prominent autonomic symptoms.
Yes, sir.
So the nerve fibers
Sir,
affected?
mainly it's a large fiber, sir.
Yes. So which are the large nerve fibers? How do you classify the classification of nerve fibers?
Sir, type 1, type 2, type 3, and type 1 against type A alpha, beta, delta, and gamma, and
Okay.
type B and type C, sir.
Okay.
Type 2 is B and type 3 is C, sir. C fibers are mainly responsible for carrying poorly localized dull aching pain. A delta fibers mainly sharp-shooting pain. So, A gamma fibers are mainly responsible for maintenance of muscle tone.
So you don't mix both of the classifications. You should always go for either one of the things. So you can go for A alpha, A beta, A gamma, delta, B, and C, or you can go for 1, 2, 3. One of that you say. So you say, you are saying right now saying A alpha, A beta, A gamma. So here, which group of nerve fibers are affected predominantly?
So mainly, mainly, sir.
I'll give you a
large
clue here. Mainly the nerve fibers which subserve proprioception are affected.
Yes, sir.
So which group? So here predominantly the patient has got A alpha, A beta fiber involvement, right? A
Yes,
delta
sir.
and C are for the
Pain, sir.
pain sensation, temperature sensation, autonomic dysfunction. So here predominantly the patient has A alpha, A beta, A gamma involvement.
Yes, sir.
Okay. Continue.
Yes, sir. Sir, on examination, then patient is conscious oriented, pulse rate 80, 100, sorry, sir, 100 per minute, it is regular, and blood pressure at 130/80, no postural drop in blood pressure, no pallor, knuckle pigmentation, no hypopigmented patches, no palpable nerves, no clubbing, icterus, rash, then skin hairs, nails are normal, no axillary and cervical lymphadenopathy, no oral ulcers, no salivary gland swelling, no spinal tenderness, no pace cavas, hematos, clawing of hands or scoliosis, no thickened nerves,
So
small joint.
if pes cavus, hematos, clawing of hands is there, what does it indicate?
So mainly in this hereditary neuropathy, sir.
Hereditary neuropathies or long-standing neuropathies, hereditary
Yes, sir.
neuropathies or long-standing neuropathies. So you mentioned there is no postural drop in BP, right?
Yes, sir.
Okay, continue.
Small joints of hands, interphalangeal joints are tender on palpation.
Okay, interphalangeal joints, any preferential involvement of interphalangeal joints are there? And
sir, mainly PIP joints were more tender, sir.
okay, so that is seen in which condition?
Pardon, sir?
PIP joint preferential involvement to DIP joint is seen in what condition?
So mainly rheumatoid arthritis, sir.
Rheumatoid arthritis. DIP joint preferential involvement to PIP joint is seen in which condition?
So SLE.
No, osteoarthritis.
Yes, sir.
Involvement in osteoarthritis. So earlier we mentioned the differentiated between inflammatory and degenerative. So even though small joints of the hand and all are not usually that affected in degenerative arthritis, in osteoarthritis the patient can have, especially in advanced cases, small joint involvement also. And if so, usually we see that the DIP joint is affected. And here you should mention other cutaneous features of rheumatoid arthritis also.
Yes, sir.
What are the cutaneous features of rheumatoid arthritis?
Sir, calcinosis in joints, then
Calcinosis in joints.
yes,
Okay.
sir, erythema nodosum, then redness.
You say the common things. Okay, continue. Calcinosis in joints, erythema nodosum.
So, on patient with chronic steroid use may have features of steroid toxicities like dry and rough skin.
Rather than that, R-related deformities are there.
Yes, sir.
Okay. So the systemic features of rheumatoid arthritis that you should remember, keep in mind in this patient, all the named deformities that they can ask.
Yes, sir.
Okay. Then
on examination of cranial nerves, vision were 6/6 on both eyes, and their pupils are bilaterally normal and reacting to light. Extraocular movement were normal. Fundoscopy was normal. Corneal reflex were normal. Facial sensation were normal. Muscles of mastication normal. Rainy test normal. Ovalized central and palate reflex were normal. On examination of this sternocleidomastoid and trapezius were normal. Then hypoglossal 12 mass were normal. Examining motor system, nutrition where nutrition was average. There was mild wasting of
bulk only you can use rather than nutrition. You can use bulk. Okay.
Bulk was normal, but there was mild wasting of thenar, hypothenar masses bilaterally. No fasciculations. EDB was preserved bilaterally. Tone was normal in both upper and lower limbs. Powers on examination of powers, upper limbs deltoid, it was 4/5 bilaterally. Both anterior, medial, and posterior fibers. Biceps 4/5 bilaterally. Triceps are on right side Sorry, sir. It is 5/5 bilaterally. Brachioradius is, sorry, sir. This brachioradius is 4/5 bilaterally. Wrist flexors 4/5, and wrist extensor was 4/5 bilaterally. Fingers flexors and extensors were weak. Neck flexors were normal, and truncal muscles was normal. Beaver sign was negative. In lower limbs, hip flexor ilios was it was plus 4/5. Gluteus maximus plus 4/5. Hip adductors was normal 5/5. Abductors 5/5. Hamstring was 5/5. Quadriceps 5/5. Tibialis anterior plus 4/5 bilaterally. Extensor hallucis longus was 4/5 bilaterally. Inversion eversion was 4/5 bilaterally, and gastrosoliar it was 5/5. Reflexes, sir, dependent biceps, triceps was normal. Supinator jerks was not seen.
Normal, you have written 1+. 1+ reflex is normal. How do you grade
No, sir.
reflex?
2+, sir. Biceps is 2+, sir.
Okay, so 1+ you have written. Don't say it as normal. So how do you grade reflexes?
Sir, 2+ is normal, sir. 3+ is bis, then sorry, 3+ is BRICS, sir. Then 4 is clonus.
So associated with the clonus is 4+.
Yes,
Okay.
sir.
So 1+ is not normal. It is just present. Reflex is just present. Okay.
Yes, sir. Then knee jerk was present, 2+. Then ankle jerk
Knee jerk
was
was
absent. 2+, yes, sir.
Really, knee jerk was 2+.
Yes, sir.
Okay. Okay.
Ankle jerk was absent bilaterally, sir.
Okay, you have a well-coming knee jerk. Okay.
Yes, sir. Plantar's reflex was flexor bilaterally. On sensory examination, sensation of touch, pain, pinprick, and temperature was normal. Joint position was normal in bilateral upper limbs. Joint position was absent in bilateral lower limbs at toes. Vibration sense impaired in lower limbs up to the lower tibia. Gait was
No, you have to tell in such a case, see, when you have historically a significant proprioceptive affection, you have to mention about the vibration sensation in seconds. Okay, vibrations. So what is the lowermost point where you check for vibration sensation?
lowermost.
You checked in the medial malleolus or?
Sir, this great toe, sir.
Okay, great toe. So you have to
Yes,
tell
sir.
how many seconds is the vibration sense, and if joint position sense, is it only abnormal at toes? At ankle level, it is normal.
So joint sensation absent in lower limbs at toes.
You have to go up and test. At the level of ankle also, you have to check.
Yes, sir.
Okay.
Yes, I have checked. Sorry, sir, I forgot to write this.
Okay, and so vibration signs in such a neuropathy case always mention at a level of grade toe how many seconds the patient was able to feel. You should have your own tuning fork, and you should know what is the number of seconds it is for a normal patient. Usually, so at level of grade toe, you in a normal person of this particular age, you expect the patient to have 12 to 15 seconds.
Yes, sir.
Yeah,
Okay.
Dr. Korean, somebody was asking regarding joint position sensation in the mandible.
In the mandible? Oh, no, I have not.
Jaw movements.
Oh, I have not.
How to check?
Sure. I am not sure. I will check and I will get back to you. I have not heard of it.
Yeah. Okay. Okay. What is some timed vibration? You have heard, Rupam?
Yeah, yes, sir. It is the standard time up to which a normal person can feel the vibration in on a tuning fork. It is normally 12 to 15 seconds. Sir.
Okay, no, the 12 to 15 seconds, it varies as you go up. For at each level, the timed vibration, what is defined as normal, varies from each joint to joint, and also it varies with age also. You will not, there is a normal age related deterioration in the timed vibrations. When an elderly person, you will not expect the person to have 12 to 15 seconds in the toes.
Yes, sir.
Okay. Continue.
So on examination of gait, gait is ataxic, wide base, short steps with eye looking downwards towards the ground, no turning difficulties, normal arm swing, Romberg's test was positive. There was no cerebellar signs, no tremors or pseudocytosis. So, on final summary.
How
Again,
you will check Romberg? How you are checking?
Sir, first ask the patient to stand with his with her both her legs kept together, then keeping both her hands on the side, then ask her to first at the keep her eyes open, then eyes closed.
Okay. How many seconds we have to wait?
Sir, 4 to 5 seconds, sir. 4 to 5 seconds.
Okay. 10 seconds, I think. Dr. Kurian, any comment?
It's 10 seconds. 10 seconds.
Yeah. And any modification of this Romberg sign you are aware?
See, in your patient here, Romberg is positive. What if in such a patient with a proprioceptive involvement is there, a predominant large fiber neuropathy is there, if your Romberg was negative, what else you should check?
Sir, tandem gait, sir.
Not a tandem gait, tandem Romberg.
Yes, sir.
Okay. So tandem Romberg will help you to pick up a patient with a subtle proprioceptive involvement. So, and especially in young people, even if there is a large fiber neuropathy, they might compensate. So a tandem Romberg, they won't be able to. So you have to ask the patient to stand with one foot in front of the other, and the same as Romberg. Keep your upper limb close to your body, and then you have to ask the patient to close the eye.
Yes, sir.
Okay. I think we have overshot the time a little. Should Dr. Shailesh and Dr. Ramakrishna, is it okay?
Yeah, 10 more minutes we can.
Yes, sir. It is the last session for the neuropathy, and you can continue, sir.
Okay.
Sir, final summary. My patient, 35 years old female.
No, regarding this joint. Okay, go ahead.
No, before going to final summary, see, you have not, in a neuropathy patient, especially with a connective tissue disorder, you have to tell about the examination of musculoskeletal system, any deformities. You have to tell about the abdomen GIT examination. Other systems also you have to tell, right?
Yes, sir. Sorry, sir. Sir, I have only, sir, written here only joint examination.
Okay.
Sir, rest of the system, sir, GIT and cardiovascular system was normal, and
you were telling, no, your negative history, you were telling about diarrhea, all those things. So even if it is normal, always mention other systems also. Especially here, the patient had Ayurvedic medicine intake. Okay, any liver, so the liver involvement, all of these things can come, right?
yes, sir.
So the other system involvement in examination, you should just mention.
Yes, sir. Rest of the cardiovascular and this abdomen middle system and this musculoskeletal system were within normal limits, sir.
Okay. Musculoskeletal system is not within normal limit. Okay. Anyway, continue.
Yes, sir. Final summary, sir. My patient, 35 years old, female, presented with insidious onset, subacute, insidious or subacute onset, progressive generalized polyradicular neuropathy involving mainly small and large fibers with motor weakness, distal more and proximal, upper and lower limbs, asymmetric without any autonomical involvement, cranial nerves.
Right now, you don't have asymmetric. No, only the onset is asymmetric. Currently, do you have asymmetry in weakness?
At present, sir, so after examination, sir, no, sir.
No, this is a final summary, right? So and also it was a few days. So it is a subjective thing, whether if you are going to say it as a symmetrical onset or asymmetrical onset. So after your examination, all the weakness was symmetric. Historically, also the weakness is symmetrical. So you say can the symmetrical weakness.
Yes, sir.
Okay.
Without any autonomic cranial nerves involvement and positive, without any positive family history, with joint pains and hypothyroidism. Sir.
Okay.
On examination, sir.
No, you don't need to tell about the examination again. You can summarize. So you can summarize. You should say as 35-year-old lady with who has presented with a insidious onset, gradually progressive, initially asymmetrical, which progress to
symmetrical. Yes, sir.
Sensory symptoms with the predominant negative sensory symptoms and a distal plus proximal weakness involving upper limb and lower limb without significant autonomic symptoms.
Yes, sir.
And in addition to that, the patient has got large plus. Here you should not say joint pains. Now you have to use the medical terminology. You have to say that a large plus small joint involvement, which points towards an inflammatory arthritis. And a coexisting comorbidity is hypothyroidism. Okay.
Yes, sir. Yes, sir.
So go for the similar thing. So what is the patient's deficit, anatomical localization, pathology, and the etiology. You don't need to say the positive things again. Go to the diagnosis.
Yes, sir. Sir, mainly, sir, polyradicular neuropathy.
No. How do you say the diagnosis in such a case?
So my patient presented with 35.
No. Diagnosis is not a descriptive sentence. Diagnosis is a point wise you have to tell. A symmetrical, asymmetrical, element pattern of weakness, human pattern of weakness. So first say the deficit that the patient is having.
So symmetrical onset, sensory motor polyradicular neuropathy.
Let's say the deficit. The patient has got a symmetrical, progressive, proximal plus distal element pattern of weakness. Is it clear?
Yes, sir.
So patient has got a symmetrical, proximal plus distal, progressive, lower motor neuron pattern of weakness with negative sensory symptoms, which are symmetrical.
Yes, sir.
No autonomic dysfunction.
Yes, sir.
No cranial nerve involvement. So here, since it is a neuropathy, you have to mention there is no autonomic dysfunction in the deficits also. So
yes,
the first part of the diagnosis is deficits.
Yes, sir.
So that has to be concise. Can you try telling once now?
Pardon, sir, I could not get it properly actually.
So the diagnosis, when you are asked to say, you have to first say the patient's deficit. This particular patient has got a symmetrical distal, subacute progressive element pattern of weakness with negative sensory symptoms which are symmetrical without autonomic dysfunction. That is the deficit.
Yes, sir.
Okay. So now you want to localize it to what is the second part? What is the anatomical localization? You have told about the deficits. What is the anatomical localization?
So mainly, sir, peripheral nerves, sir.
No, it's a polyradiculoneuropathy. It's correct. It is peripheral nerve, but it is a polyradiculoneuropathy, right?
Yes, sir. Yes, sir.
Okay, so that is the anatomical localization. Then,
Yes, sir.
is it a now the pathology? Is it a demyelinating neuropathy or is it an axonal neuropathy?
Sir, since she is presented with atrophy of the mild atrophy of the.
No. That is afterwards. You first give me the diagnosis, and then we will do posit pointers. Diagnosis you have to say concisely. When the examiner asks
Sir,
you, you have to
axonal.
say.
Sir, mainly axonal, sir.
So you want to go for axonal neuropathy.
Yes, sir.
Everywhere you have mentioned CIDP. What is the full form of CIDP?
Pardon, sir?
Everywhere you have, okay. So you want to say axonal neuropathy. Why do you say it is axonal neuropathy?
Sir, the patient does not have length dependent pattern. She's
So length
giving.
dependent pattern comes in which neuropathy?
Sir, it is more common in, sir, most commonly, sir, in axonal, sir, axonal type.
Okay, so axonal neuropathy has length dependent pattern.
Yes, sir. Hello, sir.
So here you don't have. Hello.
Hello, sir.
Yes. Am I audible?
Yes, sir.
Yes. So you have told about the deficits, and the anatomical localization is a polyradiculoneuropathy. Till
Yes,
that, it is correct, right?
Yes, sir.
So now, is it an axonal neuropathy or a demyelinating neuropathy?
Sir, since it is distal to proximal, so I would like to consider axonal more than demyelinating, sir.
Okay, so because it is distal to proximal, you want, but the patient had almost simultaneously proximal and distal involvement, right?
Yes, sir.
Okay, and the patient has got upper. Okay, again, what are the other points for an axonal versus demyelinating?
Sir, axonals are mainly length dependent.
That you
It
have
involves.
mentioned already.
Yes, sir.
Then.
Then, sir, they are distal to proximal. It is axonal in axonal and demyelinating proximal more than distal. And there is atrophy more in case of atrophy and wasting in more in case of axonal type, so, than demyelinating.
Atrophy is also there, so that is more for axonal neuropathy. Then.
Yes, sir.
Then continue.
Then, sir, in axonal, it is prognosis is good than demyelinating.
No. Diagnosis. So now.
Without involving, sorry, sir.
So you have to see the diagnosis. First part is deficit. Second is anatomical localization.
Anatomical location.
Third, you have told axonal neuropathy. Now, what is the etiology?
Etiology mostly, sir, would be due to, sir, some kind of connective tissue disorder like rheumatoid arthritis or subvasculitis. Okay.
Vasculitic neuropathy, or so you don't want to consider CIDP now.
Sir,
tell me.
Sir, since it is disease duration is going more than 2 months, so okay, I would like to consider it as a CIDP.
Okay, CIDP is a demyelinating polyradiculoneuropathy, right?
Yes, sir.
You said it is an axonal neuropathy. You have preserved ankle. We have a 2+ knee jerk which is present. You have upper limb reflexes, biceps and triceps jerk are present. The patient has got a predominant distal muscle wasting is there. So, and you said in the diagnosis, you have only said that it is an axonal neuropathy. like a mononeuritis multiplex secondary to vasculitis. You have to commit to one of these, right?
Yes, sir.
You understood my point. See, in the diagnosis, you are saying that it is, so do you think it is a demyelinating neuropathy with a secondary axonal neuropathy? A demyelinating neuropathy, once it progresses, it leads to a secondary axonal neuropathy.
Yes, sir.
So do you want to consider that as the reason for the wasting?
Sir, maybe, sir.
You understood my point. There are some odd points for CIDP, but I think maybe what you can say is that this is a demyelinating polyradicular neuropathy which has progressed and the patient has got an axonal component which is responsible for the upper limb distal wasting.
Yes, sir.
When you do a nerve conduction study in a GB syndrome early at the first 1 week, you don't have any changes in the nerve conduction study. Initially, there will be only a prolonged F wave latency. When the neuropathy progresses, you will first get a demyelinating pattern, and when it progresses, the amplitudes will come down. That is a demyelinating neuropathy which has progressed to a secondary axonal neuropathy.
Yes, sir.
Okay, so I will ask you to tell the diagnosis. You can start formulating it in your mind once more. So what I want to say here is that the patient has a simultaneous involvement of lower limb proximal plus distal muscles and upper limb proximal plus distal muscles. You have a symmetrical weakness. This is not length-dependent neuropathy. So in this setting, if you say it is an axonal neuropathy, then you will have problems. Axonal neuropathies usually occur due to chronic diseases. It has an ascending pattern. Lower limb, it will start getting affected. Once it reaches up to the knee, your upper limb will get affected.
Yes,
And
sir.
patient with axonal neuropathy don't have predominant weakness. Demyelinating neuropathy, the patients will have significant proximal weakness imbalance. A demyelinating neuropathy, once it leads to an axonal injury, then the patients can have wasting.
Yes, sir.
That is why CIDP patients have got wasting.
Yes, sir.
So you don't see a GB syndrome patient who has an acute demyelinating neuropathy with wasting. But at the same time, you see fulminant GB syndrome patients who don't respond to treatment. After some time, they will develop wasting.
Yes, sir.
So you say, and what the odd points for CIDP here are the preserved knee jerk. You are saying that the patient has a brisk knee jerk 2+, the upper limb reflexes are preserved.
Yes, sir.
So then again, CIDP with a 2+ knee jerk, if you say, so that is something that you have to recheck. So here the possibilities are, like we earlier discussed, a confluent mononeuritis multiplex, or it is a CIDP. At an early stage, maybe the reflexes are preserved. When the disease progresses, that might lead to loss.
Yes, sir.
So you say an axonal neuropathy alone as the pathology, and in the etiology, if you put CIDP, then you are inviting trouble.
Yes, sir.
Now, can you tell the diagnosis for this patient? So what, like we discussed, what are the deficits? What is the anatomical localization? What is the pathology? And what is the etiology? What are the, at least the differential diagnosis for the etiology? Try once, don't worry.
Sir, my patient
A diagnosis, when they say there is no description, don't say my patient, you can just say the diagnosis. Element pattern of weakness.
Sorry, sir.
Okay. Okay, I think anyway, this is being recorded. You can go through it. So the patient has got a symmetrical, progressive, distal plus proximal lower motor neuron pattern of weakness.
Sir.
With hypoesthesia, which is symmetrical. No positive sensory symptoms, no autonomic symptoms, no bowel bladder involvement. So the likely anatomical localization is a polyradicular neuropathy. The pathology is likely a subacute demyelinating polyradicular neuropathy with a secondary axonal damage. Now,
Yes,
the
sir.
etiology, you have differential diagnosis for etiology because of the coexistent inflammatory arthritis, and considering the patient's age, you would like to consider connective tissue disorders, vasculitis, and maybe it can even be it may be worsened by toxin exposure due to the patient's Ayurvedic medicine intake and hypothyroidism as a comorbidity. Is it clear? That is the way you have to tell the diagnosis.
Yes, sir.
Okay, so now the session has elapsed the time, so we'll just go through the, how do you want to investigate the patient?
Sir, first of all, sir, apart from our in routine investigations, sir, no, blood count, liver functions, this renal function, then hepatitis B, C, HIV, vitamin B12, then this antibody profile like.
No, before going to all those things, you first say ESR, the patient has connective tissue disorder, you are saying, no? So along
Yes,
with the blood count, you say about ESR.
ESR, CRP.
Yes.
Then thyroid function test.
Okay.
Then hepatitis B, C, then
That you have mentioned.
yes, sir. Then HIV and this serology status. Then
I think, your first diagnosis was a connective tissue disease, no? So before
yes, sir. Then
routine basic investigation, CBC, ESR, CRP, creatinine, sodium, potassium, liver function test, and very important, say urine routine.
Routine urine evidence. Yes.
First, when you see the patient in the outpatient, you will be doing blood counts. So the patients can have cytopenias. A connective tissue disorder patient can have anemia, thrombocytopenia. Yes, ESR may be elevated.
Yes, sir.
For antibodies first, don't say those things. Antibodies are all done. If the patient has got a ESR of 110 and the patient has got urine showing hematuria, you will send for ANA and ANA profile. If that is there, then you will not consider doing antibodies and other things. Correct?
Yes, sir.
So tell the basic investigations first. Complete blood count, ESR, creatinine, sodium, potassium,
liver.
Urine routine.
Yes, sir.
Okay. So
urine, yes, sir.
What did the investigations show in this particular patient?
Sir, there may be rise of inflammatory markers. Maybe this.
No, not maybe. Your patient, what were the investigations like? What was the ESR?
Sir, Bhelu, sir, she had high ESR, sir, but at this point, sir, I have not recorded service.
You don't have the values with you. So the complete blood count is very important because connective tissue disorder, the patient can have various cytopenias. Okay. ESR may be elevated. Renal function can be impaired. In polyarthritis nodosa, other conditions, other small vasculitis, the patient's renal function may be impaired.
Yes, sir.
With the liver function test.
Yes, sir.
And definitely, and then RA factor you mentioned. Anything else? What if the patient's RA is negative and you feel that it is a rheumatoid arthritis associated neuropathy?
Yes, sir.
Which other test? Rheumatoid arthritis, what is the confirmatory test?
Sir, anti-CCP.
Okay, anti-CCP. Then ANA profile.
Yes, sir.
ANCA associated vasculitis.
Yes, sir.
So here you have to think from a connective tissue disease perspective rather than a routine CIDP.
Yes, sir.
Yes. Then, so the blood investigations you do and the urine routine, chest X-ray you have to do.
Yes, sir.
Okay.
Then, sir, 24 hours urinary protein.
Okay.
Then, sir, yes, also, sir, in CBC we need to see eosinophil count in some cases.
Already. Then next.
Yes, sir.
So
then,
you do all patients 24-hour urine protein. What is the some easy thing that you can do for detecting proteinuria?
Sir, sir, this heat coagulation test.
No, for proteinuria, If urine 24-hour protein, so you might not have the facility to do, what is the other investigation with urine that will help you to roughly indicate that the patient has got this much proteinuria?
Sir,
Urine protein creatinine ratio, right?
yes, sir.
Yes. So you can do a urine protein creatinine ratio. Majority of the places, they won't be having a 24-hour urine protein, and the patient also won't be billing for 24-hour urine protein.
Yes, sir.
Okay. Then what else?
Then, sir, in serology testing, I have told, sir, hepatitis B, C, HIV, then ANA, DSGNA, then
Yes.
this RA factor, as already told by sir. Then, sir, C ANCA, P ANCA, protein C, so complement level, sir, C3, C4. Then
The complement levels only we will do if the patient ANA and all are positive, and to see if the patient is having a flare. So all the examiners will expect you to say the very simple investigations rather than the big investigations. Okay.
yes, sir.
Okay.
Then,
so
sir,
the urine investigation, serology, connected for the workup for connective tissue disorder you have sent. Now come to the next line of investigation.
sir, nerve conduction, then
Nerve conduction study. Okay.
Yes, sir.
What did
Then,
your patient
sir,
have? What did your patient's nerve conduction study show?
Sir,
Another thing I will just mention here, we are thinking that the patient might have a worsening of the neuropathy due to the Ayurvedic medications that the patient is on. So maybe you can consider doing a heavy metal panel also.
yes, sir.
You earlier mentioned about arsenic and all, no?
Yes, sir.
Okay. Then, nerve conduction study. What was your patient's nerve conduction study find?
Sir, it was, sir, it was axonal and demyelinating neuropathy, sir. Exactly, sir, sir, exactly, I did not remember the report at that time, sir.
Okay. No, because that is the clincher, no? Because now, if it is showing demyelinating neuropathy, then there is a no-brainer. It is, and if you knew that the patient's nerve conduction study is showing a demyelinating plus axonal neuropathy, then if in your diagnosis, you are saying axonal neuropathy also. So this is not a routine case presentation. This is a case presentation where you have the benefit of having access to all the investigations. This is your patient. So if you are saying that it was a demyelinating plus axonal neuropathy, then you need not have told in the diagnosis that it was an axonal neuropathy. You should not
sir, yeah, sir, sorry, sir. Exact report I did not remember, sir.
So the nerve conduction study you will do. What else?
Sir, then non-invasive test, if any, sir, there is, we suspect any lung involvement and or any kidney involvement, we may go for HRCT thorax. Then
HRCT thorax. Okay. Patient does not have any symptoms. Tell me the routine investigations for CID.
Sir, sometimes serum-protein electrophoresis with immunofixation we can do.
Okay.
Then CSF to roll out
CSF analysis. Yes. CSF analysis was done
to see albuminous cytological dissociation, sir.
In this patient, there was albuminous cytological dissociation.
Sir, no, sir. Exactly, sir. It was, sir. At that time, I lost follow-up of the patient.
I think maybe we will limit to a general discussion of CID. So, how will you investigate if the examiner is asking? Always say the routine investigation first.
Yes, sir.
CBC, ES, CRP, LFT. So, if the LFT is showing a altered albumin globulin ratio, then and a normal alkaline phosphatase, that is when majority of the times you go for a serum protein electrophoresis. You do, and we always do a serum protein electrophoresis, and if it is not showing up something, then we go for usually an immunofixation study or a light chain assay, all of those things. So not all investigations are done together. So you can say that it is done stepwise. And what are the first line investigations that you do? So the examiner also will appreciate that you are doing it step by step. Because immunofixation electrophoresis in my center costs 6,000 rupees. The patient will run away if you do all the investigations at the first site. Okay.
Yes, sir.
So tell that investigation stepwise. So the blood investigation, urine, chest X-ray, these things you will do. Then you will do a nerve conduction study. Then a CSF analysis you might do if it's a CIDP. Is there a role for MRI?
Sir, to rule out any cord pathology or any, sir,
Okay.
yeah.
Does MRI show any abnormality in CIDP?
Sir, there may be inflammation on this this nerves. We can see MRI can appreciate, sir.
Okay. Enlarged or thickened nerve roots you will see in MRI, no?
Yes, sir.
Okay. Okay. So these are the investigations that you will do, and how will you treat your patient?
Sir, if it is vasculitis, then the plane of management, we may go for steroid, IVIG, or plasmapheresis. Then after.
One important thing is that, even though you should, if it is vasculitic neuropathy and all, many a time prior to the treatment, we will do a nerve biopsy, even if
yes, sir.
Nerve biopsy, because how long to treat, or what is this? So once you touch the patient with the steroid, the biopsy picture will change. Okay.
Yes, sir.
So depending upon the pattern seen in nerve conduction study, and especially if the investigations are not contributory, nerve biopsy should be high in the list, because even lymphoma and all, they can have a peripheral nervous system lymphoma, a PNS vasculitis, where the patient's nerve biopsy only will pick up the vasculitic changes, and it will rule out a lymphoma, infectious infiltration and all. Okay.
Yes, sir.
Okay. So treatment, you will treat the underlying connective tissue disease, and you will treat the patient with?
So if steroid or this IVIG or this plasmapheresis, sir.
Okay. Okay. Okay, I think maybe we have overshoot the time, and we can. Dr. Ramakrishna, Dr. Shailesh?
Yeah.
Yes, sir. It's
yeah,
always interesting to have as a moderator for the discussion, sir.
Oh, thank you. I think I was not focusing on the time this time.
Yeah, it is the last session for the neuropathy. Dr. Shailesh?
Yeah, Kurian sir, you can give final remark, then we can close it.
Okay. So, Dr. Rupam, you presented quite well, but I think you have to be careful that you don't, you should not give ammunition to the examiner. So, and you can give ammunition to the examiner. It is a very good trick. If you can even say some things to drag the examiner. So, but what you say about Golgi tendon organ, some things, then the examiner will go from neuropathy to other systems. They will go. Then we will not be, might he not even have a chance to present your case. And once such a thing comes, then your confidence will go in that particular situation. And the examiners will not stop asking questions unless they find something that you don't know the answer to. And if you don't know the answer to, and they will ask one or two more things about that question, that in that area. So always think and answer about what you are going to say. So don't allow the examiner to go into territories that are not familiar to you. Be very well prepared, and the stock questions, definitions, the simple things, make sure that you are able to answer very fast, because the examiner will always be looking at whether he can, make you pass. The rest are superfluous, and they come with, nowadays the examiners are coming with an aim to pass you. The majority of the examiners are not toxic, not like before. Even when I used to go as a skilled assistant for DMB examiners, except for some people, majority of the people want to pass. Nobody wants you to trouble you. So just think before you answer. Delaying answering for 1 to 2 seconds is fine, rather than giving a wrong answer. And not only in neuropathy, all the other neurology cases, when you come to the diagnosis, you should say it as a point-wise. Deficits, anatomical localization, etiology, pathology. I have seen some, pathology, etiology. I have seen some examiners will come and tell you, okay, tell me the diagnosis of your case. They won't allow you to present the case only. They will just tell you, tell me the diagnosis. So at that time, if you start saying it is a 35-year-old male with these symptoms, no, they will again tell you, you tell me the diagnosis. So if you fumble there, then you are going to start fumbling at the beginning of your presentation. So always expect the examiners to have this question. In the beginning, only some examiners will tell you to say the diagnosis. Especially if it is your second or third case. One case, they will allow you to present fully, your first case. The rest of the cases, they will just ask the diagnosis. So you should have a ready-made diagnosis written and ready to say.
Yes,
anyway,
sir.
I think you can, you have, in neuropathy, you have to read very carefully. There are a lot of areas, it's not like other cases. If they go to variants of CIDP, electrophysiological criteria, we have not even touched those aspects. Electrophysiology only is a big area. Once it is neuropathy, you should be, I personally, I feel that neuropathy is the most difficult among all the cases that we have, especially if it is kept as a long case, it is going to be really difficult. So anyway, read well, prepare well. Your case presentation was good, but you were giving me many things with which to attack you. That should not be the case. And your sentences should not contradict each other. Negative history, majority of us have written down negative history points that we randomly say. But that importance that you said, it is a female patient. So then the examiner will know that you have not given thought to it and you have just said the negative history. That is not. So you should make sure that whatever you have written down, if you have time, go through it, revise. You will get time in the exam, especially for your second, third case, and then present. Okay?
Yes, sir. Yes, sir. Thank you, sir.
Anyway.
Thank you,
Yeah,
sir.
okay. Thank you, Dr. Rupam, for nice
Uh,
presentation. Thank you, Dr. Kurian, for nice interaction and good academics. Thank you, Dr. Ramkrishna.
Yeah,
Thank you,
just I
sir.
want to share 30 seconds my experience. Dr. Kurian has told very interesting experience regarding the DNB examiners. Mostly they will be non-toxic. And as sir told, my examiner is Dr. Vivek Lal sir, PGH and HOD. In the second session, when I am presenting some myopathy case, when I am commenting on winging of scapula, he didn't comment anything in entire case. Just he asked the attender that, did he examine the winging of scapula carefully? That means, has he removed the clothes? And has he taken the help of attender? That means husband. Just he asked only one question to the patient, and he told that Bhago Yase, run from the room. So examiners will be specific to some basic things. So never forget the basics. Always confine to basics. And remember one statement: DNB students will not have any godfathers.
Yes,
so
sir.
our center will be one place. Our examination will be at the different place. So thank you, Dr. Kurian, for a nice interaction.
Thank you.
Shall we close?
Yes, sir.
Right.